In this video, we are looking at the first-pass effect and bioavailability, and explaining exactly why oral drugs lose their potency. Whenever you swallow a pill, you're sending it on a suicide mission. Before it can ever reach your bloodstream, it has to run a microscopic gauntlet of acid, transport gates, and a highly coordinated assassination attempt by your own liver. This entire survival journey is called pharmacokinetics, literally what your body does to the drug. It's a four-step process: absorption, distribution, metabolism, and excretion. But today, we are focusing purely on step one. Absorption is the movement of a medication from its site of administration directly into the systemic circulation. And to do that, our little pill has to break through a wall.
All right, let's zoom in and look at the actual battlefield. Before a medication can do its job, it has to get from the outside world into your bloodstream. But to reach the systemic circulation, drugs must cross semi-permeable cell membranes. I want you to look at this membrane not just as a wall, but as the strictest, most unforgiving security checkpoint in your entire body. This barrier doesn't care how expensive the drug is or how badly you need it to work. Getting inside is a physics problem. Success depends on the drug's molecular size, lipid solubility, and degree of ionization. If a drug is too large, it is instantly rejected. If it carries an electrical charge, meaning it is ionized or polar, it bounces right off the fatty lipid bilayer. But if a drug is small and lipid soluble, it essentially wears a camouflage jacket made of the exact same material as the wall itself, allowing it to ghost right through the passive diffusion gate.
So, we know the bouncer is strict, but pharmacology is all about finding loopholes. There isn't just one way into the cell. There are exactly 3 distinct mechanisms of cellular transport. Let's break down how different drugs exploit these pathways. The first is passive diffusion. As we saw, this requires absolutely zero energy. It is the ideal, frictionless pathway for small, lipophilic, and unionized molecules to slide right through the lipid bilayer, or slip through an open carrier protein gate. But what if a drug is water-soluble or slightly larger? It has to use active transport. This is a toll booth. It requires the cell to actively expend energy. To use this gate, the drug has to be structurally similar to endogenous substances, meaning it has to wear a disguise, mimicking things your body naturally wants to absorb, like vitamins, sugars, or amino acids. Finally, we have pinocytosis. If a drug is a massive peptide or protein, it will never fit through a standard gate. Instead, the cell membrane literally reaches out and engulfs the drug, swallowing it whole in a massive expenditure of cellular energy. So, we've established that the cell membrane is a strict bouncer. But the biggest deciding factor for whether a drug actually makes it through that lipid bilayer is the environmental pH. Here is the reality. Most drugs are weak organic acids or weak organic bases. And here is the golden rule of pharmacology you must memorize. Drugs cross cell membranes easiest when they are unionized, meaning they are lipid soluble and carry no electrical charge. Let's see what happens when we drop these 2 different drugs into the harsh environment of the human stomach. Because the unionized form penetrates membranes, weak acids absorb highly favorably in the highly acidic stomach. It's a matching environment, so they keep their disguise. But weak bases? The moment they hit that stomach acid, they react and remain completely ionized, meaning they are electrocuted and trapped. They cannot pass the barrier. They have to wait, traveling further down the GI tract until they finally reach the alkaline environment of the intestines to absorb. So, our little drug survived the stomach acid and successfully crossed the cellular border. It's in the blood. Victory, right? Not exactly. You see, the drug thinks it has reached the general circulation, but it has actually walked right into a trap. When you take a drug orally, the blood vessels in your stomach and intestines don't just dump into the rest of your body. They all converge into a single mandatory toll road called the portal vein. And this highway only leads to one place: the liver. The liver is the body's ultimate security checkpoint. Its primary job is to protect you from toxins by metabolizing them before they can reach your brain or heart. And unfortunately for our medication, the liver doesn't know the difference between a life-saving drug and a deadly poison. It just sees a foreign chemical, and it unleashes an army of digestive and hepatic enzymes, most notably the CYP450 family, to tear it apart. To truly understand how brutal the first-pass effect is, we need to put some numbers to this massacre. Because the reality is, the first-pass effect drastically reduces the concentration of active drug available to exert a therapeutic effect. Let's say you administer a standard oral dose of a medication. We'll represent this dose as 100 perfect active drug molecules. The moment they enter the GI tract, the attrition begins. Between stomach acid, digestive enzymes, and poor absorption, we immediately lose 20 of our molecules. But that's just a scratch compared to what comes next. The survivors hit stage 3, liver metabolism. Here, the hepatic CYP450 enzymes launch an all-out assault. For many drugs, this checkpoint is an absolute slaughterhouse. In this scenario, the liver shreds and destroys 50 of our remaining molecules. Finally, the battered survivors exit the liver. Out of the original 100 molecules, only 30 make it into the systemic circulation to actually do their job. This massive loss creates a profound clinical consequence. It means that oral doses of high-clearance drugs, like Propranolol or Morphine, must be significantly higher than their intravenous counterparts just to achieve the exact same clinical effect. You aren't just dosing the patient, you are paying a massive tax to the liver. Those 30 surviving molecules from our liver massacre, they represent a crucial pharmacological concept called bioavailability, represented by the letter F. By definition, bioavailability is simply the fraction of the administered dose that successfully reaches the systemic circulation in an active, unchanged form. If you administer a drug intravenously, or IV, you are directly injecting the payload into the vein. Absorption is bypassed entirely, which means IV drugs have 100% bioavailability. But oral medications, PO drugs, will always have less than 100% bioavailability. And unfortunately, that percentage isn't a fixed number. It varies wildly based on exactly who is taking the pill. The journey from your mouth to your bloodstream is incredibly volatile. 3 massive clinical variables can completely disrupt oral absorption, turning a safe dose into a useless one, or a toxic one. First, formulations. If a nurse crushes an enteric-coated or sustained-release capsule, they destroy the drug's protective mechanism. The drug is released too early and gets completely destroyed by fatal stomach acid before it ever reaches the intestines. Second, gastric emptying. The small intestine is where most absorption happens, but if you take a drug with a heavy, fatty meal, that food slows down gastric emptying. The drug gets stuck in stomach traffic, severely delaying its arrival to the intestinal mucosa. Finally, biological age. Neonates and infants lack mature acid-producing stomach cells, meaning their gastric pH is much higher. Worse, their livers are immature. This results in vastly decreased first-pass elimination, meaning an unpredictably massive amount of the drug hits their systemic circulation, risking severe toxicity. So, if the stomach is a volatile swamp and the liver is a literal meat grinder, how do we guarantee our patient gets the exact dose of medication they need to survive? We cheat. Clinicians exploit alternate administration routes to bypass the portal vein entirely, delivering the payload directly into the systemic capillaries.
Think of these routes as tactical insertion points.
Sublingual and buccal tablets dissolve under the tongue or in the cheek, instantly entering the oral mucosa capillaries for incredibly rapid onset. Transdermal patches absorb steadily through the skin directly into local capillaries for long-term delivery. Inhalation crosses the massive surface area of the pulmonary alveoli, and intramuscular or subcutaneous injections drop the medication directly into muscle or fat beds. Every single one of these routes shares the exact same objective: sneak the drug into the systemic circulation while keeping it entirely off the liver's radar.
So if bypassing the liver is so great, why don't we just give every single drug through an IV?
Because in pharmacology, every single route is a strategic tool with its own unique trade-offs. Let's look at the clinician's playbook. Intravenous, IV, is the ultimate power move. It gives you 100% bioavailability and completely bypasses the liver. It's rapid and complete. But the constraint? It's irreversible. Once you push that plunger, you cannot take it back. And you introduce a risk of infection. Oral, PO, is the default. It's convenient and economical. But as we saw, you pay the first-pass penalty, meaning bioavailability is highly variable, less than 100%, and the onset of action is much slower. Transdermal patches give you a beautiful, steady, long-term systemic delivery with a full liver bypass. But remember our lipid bilayer bouncer? This route is strictly limited to highly potent, small, lipophilic molecules that can actually penetrate the skin. Rectal, PR, is the wild card. It partially bypasses the liver and is incredibly useful if the patient is vomiting or can't swallow. But the absorption rate is completely erratic. Finally, parenteral injections like IM or sub-Q offer high bioavailability and full bypass. They are amazing for slow, sustained depot delivery, but they rely entirely on local tissue perfusion, meaning if there isn't good blood flow to that muscle, the drug isn't going anywhere.
To master drug absorption, you have to think on 3 different levels. On the microscopic level, you must remember that absorption is a cellular conflict. A drug must be the right size, lipid-soluble, and unionized to successfully breach the lipid bilayer. On the macroscopic level, you must respect the first-pass penalty. Oral medications face massive enzymatic degradation in the gut and liver, requiring precise bioavailability calculations to ensure the patient actually gets the therapeutic dose. And finally, on the clinical level, administration routes are your strategic tools. By understanding anatomy, you can select IV, IM, or transdermal routes to bypass the liver entirely, ensuring the optimal payload reaches the target tissue. Now that you understand how a drug survives the gut and liver to reach the bloodstream, you aren't ready for the absolute chaos of where it goes next. Until you see this video on the volume of distribution and the blood-brain barrier.